Hello everyone, this is Héctor Valenzuela coming at you from Guadalajara with yet another video of preperitoneal eTEPP. You can see here the anatomical layers of the suprapubic axis. We are strictly preperitoneal in this part of the surgery as we want to preserve the retrorectus space. We are dissecting on the left side of the patient, making sure we just develop enough space for the trocar placement. Now we go to the right side of the patient in the preperitoneal space, pushing away all these epimesia and making enough space so we can put in the initial trocars. So we're going to use a bladeless 5mm port on the left side and the same thing on the right side. I think there's value in using bladeless trocars because I don't see the epigastric vessels and I don't want to injure them. I noticed that I am behind the median umbilical ligament, and as this is my primary reference in this part of the abdomen, I want to be superficial because this is a thicker structure that will prevent me from developing an early pneumoperitoneum. There you can see the posterior rectus sheath on the right side and the left side, the arcuate line, and where the actual fascia begins. And this is important to locate because I want to hug the fascia and stay very close to it in order to avoid as much as possible and for as long as possible the peritoneal rents that so far seem to be inevitable in these cases. As I mentioned, I stay superficial to the median umbilical ligament and I continue my dissection cranially, and I want to start from medial to lateral. And I don't want to go too lateral just yet because that's where the peritoneum becomes really thin. On the area of lateral to the median umbilical ligament and the falciform ligament, there are always going to be these perforator vessels that I have found it's easier to dissect around and cauterize or seal with the ligature because they don't produce a lot of bleeding, but they sure can make the operative field a little dirtier and the dissection a little more bloodier and more uncomfortable. So there's a tiny umbilical hernia that I'm reducing. This actually wasn't very symptomatic for this patient. In the other hand, she had a couple of epigastric hernias, primarily one epigastric hernia that was very symptomatic and caused her to have pain. Alongside rectus muscle diastasis, that was the primary reason why we elected to do this kind of repair. So I'm navigating now superficial to the falciform ligament. You see the tiny epigastric hernia that we're reducing, and you can see there in the far end of the screen the bigger epigastric hernia. So I try to reduce it. I see that the contents that are incarcerated inside of it are hardened and difficult to bring back into the abdomen. So I elect to dissect around, show a nice volcano sign, and see if this has loosened it up. I pull again on it and it's still very hard, and I don't want to leave decapitated fat in the subcutaneous space, so I do a longitudinal incision on the midline. I don't worry about this incision because I'm going to close all of this in the end, but this will allow me to reduce back into the extraperitoneal cavity all the incarcerated contents. And from here on, I'm just gonna hug the posterior rectus sheath and the fascia of the midline and make my way up until I can confirm that I am close to the xiphoid process. So this is the dissection almost finished. So after I have dissected everything that is safe, I now want to dissect lateral to the falciform and the median umbilical ligament. This is the part that is always harder. The feedback that I've got from other surgeons performing this procedure is that this is precisely where they get the most peritoneal rents. So what I have been doing in the recent cases is, instead of coming from medial to lateral, I am coming from lateral to medial because I want to get in the pretransversalis space before the pretransversalis fascia becomes condensed and joins the rest of the posterior rectus sheath elements to form the midline. As you're going to see in this video, this is allowed me to keep to a bare minimum the peritoneal rents that I used to have in almost every single patient that I've done this procedure on. Nevertheless, it's something that needs to be done very cautiously, very slowly, gradually. You need to be very patient and allow the pneumoperitoneum to help you dissect this space. I measure that I don't over dissect. I don't need more than 6 centimeters on each side. So I decided to finish the dissection on the right side of the patient over here. You can see in the bottom of the screen how the configuration between me and my assistant and the way we're working. And as I mentioned earlier, I start lateral. I get on the pretransversalis plane, and I try to develop a cave between the rest of the elements of the posterior rectus sheath and the pretransversalis fascia. And I keep going on this cave in order to recruit as much transversalis fascia as possible to have a more thick and reliable posterior layer. As I mentioned, also this has allowed me to keep the peritoneal rents to a minimum, but as you're going to see, in this case I got a little too confident and I thought I had dissected very nicely, and I did open the peritoneum. It's no biggie. We can close with 2.0 Vicryl. So you can see on the right side of the screen the cavity, and on the left side of the screen we're connecting this cavity with all the rest of the preperitoneal dissection. But over here I opened the space just because I was too confident. So it's not a problem to bypass this area. I go beyond where the rent is. I get back on the right plane, and then from that point and on, I'm going to hug the posterior rectus sheath, finish the dissection, and just in the end do a simple suture of this space, which, by the way, in this patient was very nice because she had a very thick and compliant transversalis fascia and peritoneum. This is the only rent that I had to close in the end of this procedure. This is the final dissection. You can see the epigastric hernias over there and the umbilical hernia along with the wider area of diastasis in this area. There's a scheme of how everything looks. And for cosmetic purposes, we are closing this patient. She's a thinner lady, and she cares about the way her abdomen looks, so we're closing her with the non-inverting plication. It is of the essence that you can do backhanded suturing because you have to go back and forth the same way the needle goes in. There you can see also the configuration of how we're holding the instruments and how important it is to clear the space in the suprapubic area so the hands can move freely. And this is just gonna go showing how when you do this suturing in the proper fashion, all the excess fascia is going to be inverted into the extraperitoneal cavity, leaving the subcutaneous space without a ridge, which is very nice for the patients. But in the end of the procedure, you can touch the space and you can see how solid it is and how the rectus have come together in the center. Most of these patients I follow up in my office with an ultrasound. I have a portable ultrasound that I use in the office. And every time they come, I do an ultrasound just to show them how their muscles are back together in the midline. And they're usually very excited to see that the muscles are back together. You can see every time we throw a stitch, we have to cinch in to make sure we reapproximate the rectuses, and we have a better chance that the needle can go through and through from one side to the other. Otherwise, the distance is going to be too big and it's going to be difficult to go through the rectus space. If you pay attention closely, in the top of the screen, you can see the rectus actually forming an angle at the level of the umbilicus, and how they are coming together very nicely. And if you follow along the midline, you can see all the excess fascia inverted. This is a video we take from the outside. This is actually a different procedure, but it's just to illustrate how, after having plicated the excess fascia, the abdomen looks flatter during the procedure in comparison with the area where the fascia has not been plicated yet. So the results are usually immediate. We continue plicating only to the level of the arcuate line. There's no point in doing a plication, or I find no point so far in plicating below the arcuate line. I think I will be just probably causing some pain due to the ischemia of the muscles that I am taking with the bites of the suture. So when I am satisfied and the diastasis is completely obliterated, I'm going to run back the suture and lock it on itself, just to make sure it's not going to be loose. And in the end of the case, we look at the dissection we've just created. You can see the posterior rectus sheath is whole, and the pretransversalis preperitoneal space in both areas is well dissected. All the excess midline fascia, it's imbricated into the extraperitoneal space, and we measure the space and cut a mesh to fit exactly our needs, because we wanted to be covering and reinforcing everything that we just dissected. Carefully remove the CO2, and this is the end of the case. Thank you very much for watching.